Good morning, everyone, and welcome to our PDAB webinar. I'm Mike Egang, and I'm with the Rare Access Action Project. And we're very pleased to host this webinar this morning and include a panel that really is going to get into some topics that we've alluded to on some previous webinars, but that we'll be addressing head on and fairly directly today. And so I'm really excited about the topics. We're going to be first talking about New Hampshire, the experience there, as well as the subsequent repeal of the PDAB. And then towards about halfway point in the webinar, we are going to include an additional panelist, and we'll be talking about MFP and MFN, both acronyms which we've mentioned in past webinars. But we'll be talking about most favored nation and maximum fair price, which are being looked at as tools and as surrogates for UPLs in some states. So it's a really jam-packed discussion today. I think there's going to be a lot of good information and discussion. As always, I would encourage you as participants to please feel free to submit questions. We often take questions from our attendees and discuss them with the participants on the panel. And that's a really terrific way to get at additional information. So please feel free to use that function within Zoom. So now I'd like to turn to our two panelists and welcome Bill Murphy, who has worked with disability issues for over 45 years. He started his career as a special education teacher after attending Syracuse University. In 1980, he became the founding member and first executive director of what was then called the Epilepsy Association of Greater Boston and is now Epilepsy Foundation New England. In 2005, Bill went on to work for the National Epilepsy Foundation as Director of State Government Relations until retiring in 2013. But his retirement didn't last long, and in 2014, Bill returned to the policy arena as the local Epilepsy Foundation affiliate, serving as the Director of Advocacy and Public Policy for the Epilepsy Foundation New England. Annually, he conducts the Epilepsy Foundation's program, Teens Speak Up, bringing teens from around the country who live with epilepsy to learn about advocating for epilepsy and to visit with their legislators on Capitol Hill. Now living in Newport, Rhode Island, Bill can often be found on the highway traveling throughout New England to promote public policy that benefits people living with epilepsy and their families. So welcome, Bill. It's great to have you as part of our workshop this morning.
Great. Thanks, Mike.
Mike.
Yeah.
I was just going to introduce Rainier.
Oh, I'm sorry.
And I'd also like to introduce Rainier, who is the PDAB Director of State Policy for the Community Access National Network, or CAN. CAN is a national nonprofit organization focusing on policy issues relating to HIV/AIDS, viral hepatitis, and they support all chronic disease patient communities. I've worked with CAN for a number of years and am very grateful for their participation in the PDAB work and allowing us to have Rainier for the morning. In addition to his PDAB work, he's involved in various endeavors to support CAN's efforts involving state and federal advocacy. Rainier's a freelance writer, consultant, and he also does data analytics. So welcome, Rainier, to the panel, and we look forward to the discussion. So Bill, please, I'll turn a few minutes over to you to talk about maybe setting the table for us on what happened in New Hampshire. And then we can broaden that out into some specific conversation discussion points.
Great. Thanks, Mike. And thank you for including me. As Mike said, I'm Bill Murphy, Director of Advocacy and Public Policy for Epilepsy Foundation New England, serving the more than 100,000 people in the 5 states that we cover, including Rhode Island, Mass, Maine, New Hampshire, and Vermont. Keeping track of 5 states is a daunting task, but we do our best. And in that arena, we promote and support epilepsy-specific legislation such as our SUDEP bill dealing with sudden unexplained death from epilepsy, an epilepsy school, seizure safe schools. But we also spend equal amount, if not more time, working in coalition with other groups throughout the area um, on accessibility and affordability issues, mostly accessibility, it seems. And also working on any kind of efforts to promote research for the development of new drugs, devices, or other interventions. Um, I want to say right up front, I'm not an expert on PDABs, so I'm going to learn a lot from today's session also. But that being said, I'm not an expert, but I did have the good fortune of getting an op-ed piece run in the Concord Monitor, the major newspaper in Concord, New Hampshire. We looked at that as an opportunity when they got rid of their PDAB. We saw that as an opportunity to acknowledge and thank the legislators for not only defunding it, but actually getting rid of the PDAB board and using that opportunity to encourage other states to follow suit. So, it's my understanding that 6 states do currently have PDABs, and New Hampshire and Ohio were the 2 that got rid of their PDABs. You know, I look at the PDABs as part of our work, mostly in coalitions around accessibility and affordability, as just one more barrier to people accessing the treatments that their prescribers feel is best for them. They come up with all these barriers that have fancy names, PDABs and step therapy and accumulator adjusters. But I saw this as an opportunity to just shed light on yet another barrier to access and affordability for it. Not just people with epilepsy, but across the board, people living with chronic conditions and chronic diseases. And so we wanted to acknowledge what happened in New Hampshire and hopefully encourage other states, other legislators to follow suit. Now, how it was done, getting an op-ed piece is oftentimes just gratuitous and the result of just using your contacts. And that's, I feel, how this came about. We have a wonderful network. We call all of our agencies have advocates. We have our grassroots advocates, but we established a program called Epilepsy Envoys. And to be an epilepsy envoy, we tell these folks up front, we're going to expect more from you. We're going to expect you to submit op-ed pieces. We're going to expect you to prepare testimony, to show up at the State House, to visit with your legislators. I don't know how many people are familiar with the New Hampshire legislature, but they have 400 members in their House of Representatives. It's the 3rd largest legislative body in the world. It's very hard to reach out and have personal contact with 400 legislators. But I will say our envoys, they go through training, do a tremendous job of putting a face to the issue and following up and contacting legislators and all the states we did. So anyways, going back to the specific op-ed piece we had, again, it was to just thank New Hampshire for getting rid of their PDAB board and not just simply refunding it. Certainly we recognize that, from the sound of it, it's an admirable goal. Everybody wants to lower prescription drugs for patients, but the structure they had in place simply wasn't going to achieve that. As you probably already know, the primary tool that PDABs use is the upper payment limit, the UPL, which would cap the amount insurers would cover for certain drugs. And this group, probably more than ever, more than any, certainly recognizes the treatments for rare disease. The treatments themselves are rare. and oftentimes inexpensive. Um, but upper payment limits don't lower what patients pay at the pharmacy. They simply squeeze the pharmacies and the doctors. Um, you know, and our other point simply was that PDAPs rarely engage the people that they're going to mostly impact, who are going to be affected by the decisions they make. Um, so that's it in a nutshell. We also wanted to point out there are better ways to focus on drug pricing. We know it's being considered at the federal level, but we just, to me, it's a matter of educating legislators on these very complex issues. And I have to say again, we rely a great deal on our envoys to have those personal connections, to help legislators and decision makers understand the impact that not just PDAPs, but all these other barriers that seem to be facing people living with chronic conditions and disabilities face accessing the appropriate treatments. So that's it in a nutshell. We relied on our contacts to reach the press, used our network, and we were very fortunate to get this piece printed in the paper. I'm happy to answer any questions about the process we used, but I think you have probably many great advocates on this who are also familiar with the process. So that's it in a nutshell. Um, I'm happy to answer any questions about what we did or other areas that we're engaged in. So that's it, Mike.
You muted.
You're muted, Mike.
Sorry, that was my bad. So Rainier, as we had listened to Bill, and he talked about the desire to not only defund the PDAB, but also then repeal the PDAB. Um, can you talk to us a little bit about some of the community efforts, some of the thinking around why it was important to do both, and how that kind of resets the discussion around PDAB?
Sure. I was going to quick note. I was going to thank Bill for mentioning, mentioning the importance of public input and getting the op-ed piece out there, because that's one really great tool. But to your point, Mike, so the biggest issue that was behind it being defunded was basically because it was seen as it was ineffective. The state legislators were concerned about different budgetary, issues that are coming up and trying to find ways to kind of like trim the fat because they have so many different cuts coming down because of state and federal policy issues. And analyzing the board's activities, especially since they actually have legislators that are on the board, they realized that it was just simply ineffective. They realized that the suggestions that was coming out of the board it wasn't really robust discussion. If I'm not mistaken, one of the I think it was a House committee meeting that mentioned one of the last annual reports that there wasn't enough even like public analysis as far as like public feedback and things of that nature. I think in my notes in that just in general didn't provide any kind of valuable insights at all. So it was important to one defund because it was the waste of the money, but to actually repeal it because just the whole way it was set up, and the idea behind it wasn't being useful. It was kind of set up in a rush, like legislatively after COVID, I believe, and just the way it's set up, it wasn't even put together to allow them to even have a chance at success.
That's really interesting, and part of what you had talked about, Rainier, is that New Hampshire being unique in that they actually had legislators on the PDAB,
Mhm.
and I can obviously think that that would lend to a very different dynamic when you have state legislators actually in the inner workings and seeing the challenges with implementing a PDAB. The other thing, Rainier, I would like to ask you about, New Hampshire is one of the states that doesn't have a UPL. So at the end of the day, what tools did they expect to use? And was that part of, the discussion? And instead of pursuing a UPL, they decided to repeal. Was that a factor there? Or, what was part of the thinking beyond just the costs?
Well, like you said, they did not have UPL authority. I remember part of discussions they had talked about it, and before this all happened, we were kind of assuming that that was something they were going to eventually maybe even possibly ask for. But they didn't have that many tools because most of their discussions was focused on drug pricing and coming on drug pricing lists and things of that nature, which are kind of redundant. I think one of the suggestions they sent to legislative bodies was concerning expanding state access to things like biosimilars. And I felt like they just really didn't have a good handle on really digging into other tools that they could use. That makes sense?
Mhm. That does make sense. And and I'll open this question up to both of you. As you listen to the debate around repeal of the PDAB, we some of the things that Bill you pointed out in terms of, participation with patients and providers and pharmacy, and Rainier, as you've also pointed out, in terms of being able to understand data and then being data driven in terms of decision making. Those are some of the very similar challenges and feedback that we get from our participation in Colorado, in Maryland, and in other states that are moving forward, is those are the same issues that the rare patient community, and I know working with both of your communities, that we've heard it from other patient groups as well. Can you talk to me a little bit about that kind of structural issue? And, it seems to be something that is universal to PDAB in terms of how it engages and the communities that it engages.
It is. So what I've found is that um, as far as analyzing information, the way that even New Hampshire or all the PDAB boards in general, they are strictly focused on one, just the price of drugs. That's the biggest thing to focus on. Even their statutory language focuses on the actual list price of drugs to even tell them what drugs they can even look at. So all of their data and things they look at is focused on that. And a lot of the data they're looking at is not even complete. It doesn't even include some of the more important numbers that they need. Most of them do not get appropriate patient feedback. The small amount of time they do give the patient feedback, they usually don't really even consider it that deeply. And all across all the different states, it's always a point of contention that people who give verbal comments, written comments, people who like write op-eds, that's the biggest thing they try to drill into them is like you need to talk to the people you're going to affect more. They have a habit of just sitting behind the numbers that they're getting from like insurance agencies and all payer, data databases and things of that nature. But they don't consider the aspect of the implications to their own state, financial legislators, budgets rather. They don't consider the effects to what actually can happen to patients really at the pharmacy counter. They're just strictly focused on pricing. And when you look at that data in that aspect, you're missing out an entire worldview of things that really affect what's going on as far as costs for patients.
Bill,
I think another point is that none of these savings go back to the patients. It's not saving the patient anything, paying the drugs. Now, another point I wanted to make was in regards to our op-ed piece in the paper. Thanks to social media and everybody has access, there was some blowback. One individual in particular was pretty persistent. I'll summarize it saying, how dare the Epilepsy Foundation weigh in on this when epilepsy, 70% of people with epilepsy, their seizures are well controlled. Well, first of all, that number is wrong in itself. So this was on social media. So we wanted to see if that was going to gain any traction, and it didn't. So we didn't respond because we didn't want to get into this back and forth social media argument. But if we did, my thing would have been, well, 30% is still a high percentage of people whose seizures are not well controlled and who need access to new treatments.
well, thank you for that, Bill, because you actually responded to one of the questions I was going to move to from one of our participants in terms of the short-term blowback. And what was the pushback in terms of that? Obviously, there were budget implications, and legislators were they're facing a tough fiscal year in 26. So that's interesting that what you shared with us. Rainier, did you see any other blowback from the repeal effort and issues that may need to be addressed moving forward?
I only blowback I really noticed were just from proponents of the PDAB, that were kind of like alarmed that they had gotten rid of it, and the kind of general sentiment from all the proponents that were not happy was, how do you get rid of the only tool that New Hampshire had to help patients with their, affordable their medications. But when I see things like that from them and just other different states, it's kind of concerning because from people who really understand how PDABs will operate, don't really understand, they're not really getting the fact that the mechanisms they're trying to use really don't affect the cost of drugs, in a positive way for anybody. That the only thing that really does is potentially cause barriers. It may give you some savings for the system, but ultimately it does not help patients. So I usually find that when I see the proponents who are kind of like blowing back really negatively against it, it's because, while I understand they're really frustrated and, prescription drug price is a problem thing, something needs to be done, but they don't seem to really fully understand how these boards have operated and why it's important to either get rid of them or drastically change how they're operating.
And I know that we as an organization have been very focused on the necessity to begin to move towards looking at benefit design and how we can drive value back to the patients, as Bill brought up, just a few minutes ago. And that benefit design really is the area where there can be collaboration. We were going through some of the recommendations from the Oregon PDAB members just a few weeks ago as we were preparing for their upcoming hearing. And there were a lot of creative recommendations to allow the PDAB to, kind of deprioritize a UPL and deprioritize price control and to start looking at ways that benefit design can bring value back to patients and lower their out-of-pocket costs. And so I thought that that was a creative kind of unique discussion so that, as you said, Rainier, the PDAB doesn't typically get equipped with the tools it needs to lower patient out-of-pocket costs, which is a flaw. PDABs are flawed in terms of their design. And there may be opportunities for us to collaborate and work together on some of these areas that can bring benefit back to the patient, lower their costs, and allow them to have broader access to the therapies they need. So I'd like to kick it over to you, Rainier, because I know Can thinks about this quite extensively as well.
Yes, from your point. So I'm sorry about that. Okay. Um, to your point, yes. Well, specifically Oregon, I was positively, like, really, it was great to see their like further advancing and kind of expanding their discussion ideas of things of that nature. As you said, statutorily, a lot of these boards are set up to fail because the literally focus is you have to look at this cost measure of this medication to choose drugs to analyze. And I think it is important for all of the boards to move more towards really digging into what is causing patients issues with affordability. And that is not just the list price of a drug. Um, it would be very important for some of these boards to get more, I guess, legislative leeway to explore other options. Like you said, digging into formulary design, insurance plan design, pass-through issues. But unfortunately, the way they're set up, their kind of hands are tied and they don't have any means to affect it. But definitely looking at those things, especially for things like an up payment limit, that can actually adversely affect formulary design, as we know. So it's really important to get them to move towards really focusing in on what really drives affordability questions And that would also require them to really, really dig into talking to their patient populations, talking to organizations in their states that have access to their patient populations, because with a lot of them usually have the complaint is that they reach out and don't get feedback. But as we're seeing, we don't feel they're adequately really reaching out. They have access to a lot of different organizations in their states and communities who actually have access to the patient communities. It's just important for them to reach out to those people to actually access those people.
I think that's an important area for exploration for PDABs moving forward. Because as you pointed out, in Colorado, we just saw the UPL placed on a product, and some of that was based on feedback from 18 patients across the state of Colorado. And of those 18 patients, most of them had insurance coverage, and according to the state's own data, their copays were $50 or less. And yet the product was put into a UPL situation and a price control imposed. So there is disconnect between what the patient is feeling, and it's often the patient is feeling something that has to do with benefit design, the cost of my copays, cost of my premiums, what they cover and won't cover. Will they accept my copay assistance? Will they, all those things. And yet we put a price control on a product, assuming that will take care of everything downstream, and it doesn't, as you and Bill have pointed out.
And they also forget about, well, not forget, but they ignore the fact that there are a large number of people who are uninsured, and things of that nature will not, benefit design and UPLs of that nature. They won't help people who don't have, insurance at all. And so those are people who have serious affordability problems that need to be addressed as well, that they're not looking at.
Yeah, I had mentioned I'm certainly not an expert in PDAB, and listening to Rainier and Mike speak, they know a lot more than I do. And one of the different PDABs where they do exist, do any of them have an allowance so that if they're looking at an HIV drug, if they're looking at an epilepsy drug, does the structure allow for them to bring experts in that area, not permanent members of the board, but if they're looking at epilepsy drug, will they bring in an epileptologist, or will they bring in an HIV specialist?
So that's an interesting discussion, Bill, and it's one that we have been told by some of the PDABs that they certainly are doing that, but then it's really hard to see evidence of them doing it. At the same time, some of the states do have, for example, RDACs, Rare Disease Advisory Councils. And we know in a couple of states that there has been linkages. For example, Minnesota, where we talk to the RDAC regularly, and the chair of the RDAC. We know that there's conversations. But for example, we also know that in Colorado, that outreach wasn't made to the RDAC when they were evaluating, a number of rare disease medicines, and then, put those medicines through the process. That linkage wasn't made.
Right.
So at RAAP, we are supporting some model language that would require those things you just described, Bill. Is that both a patient and a provider who actually specializes in that disease would be impaneled, not just as advisors for that decision making or that discussion, but as voting members, which we believe will change the dynamic. When you have a patient who has a vote on that board, whether it's a P&T committee, a DUR board, or even a state with a PDAB, that will change the dynamic, knowing that that person has a say and that vote matters. So those are some things that we're looking at as tools to potentially, inject the patient voice into the discussions in a way that it is not currently. I do have a comment, a couple of comments that I wanted to share with our panelists. And then, Kelsey, if you could just let me know when Jason joins us, we'll introduce him and we'll get moving in that direction. But I first wanted to share that Lauren shared with us that the Oregon employee insurance programs are generous, and that state employees sometimes do not understand the issue, so they don't weigh in. And then
Mike, Jason has joined us. He just needs to share his camera.
Okay, I will introduce him in a moment. Thanks, Kelsey. There is potentially even some disconnect on the staff that are tapped by the PDAB to help get the information and put together some of the talking points and procedures and assessments. So I think that might be the point that Lauren's making. Rainier and Bill, now that you're looking back at New Hampshire, what are some key learnings that you think that could be helpful to the patient community as we prepare for 2026? And then we'll shift the discussion now that Jason's joined us after your two final comments.
I would say one, especially looking at the failures of the board, it's really important for patients and advocates to really hone in on highlighting where the different state boards' weaknesses are and reiterating it, highlighting where their analysis problems are, where their issues with the data they're looking at, with their how they're even considering certain pieces of data, and even the fact that sometimes they don't even have a good handle on what they're looking at with the data. They're just kind of like looking at numbers and talking about it, but they're not giving any indication on what their actual focus is going to be. So I think it's really important for people to really focus and highlight these problems with the boards and that nature. And also, I think it's really good thing to kind of look at how the board is structured and who's involved with the board and try to find legislative advocates that you feel would probably be someone good to really like talk to and get relationships with to kind of influence things of that nature, to one, and either influence to either possibly get some of the funding taken away, or influence and put pressure on the board to make necessary changes if they're going to keep them in existence.
Terrific guidance. Bill?
I would second everything Rainier said. We find oftentimes when we're introducing a new issue, oftentimes a new barrier to access to people. Our advocacy efforts and public policy, we all understand because we do it every day, but it can sound very wonky to the patients. So really educating them on, not only what the policy is, but how it impacts them, and work with them to enable them and give them the tools to tell their personal stories so they put a face to these issues, and how to, the basics, how to reach out to your legislators, how to reach out to a policymaker, opportunities to participate, give them those opportunities and the tools to participate, and to follow up. We spend a lot of time with our envoy advocates about the follow-up procedure to stay engaged. That's how legislators get to know you as the face of an issue.
Terrific. I echo both your comments and wish to associate myself with them. They were spot on, and developing those relationships is a long-term effort. You can't just fly in and fly out and expect to have a relationship. It takes time and commitment and being on the ground. And that's why local advocates are so important. And it's an area, I think, at least from the rare disease community, we need to do better, so that we are involved when those discussions occur late at night. We are involved when the conversations occur in the cafeteria or the committee room, so that we can be both of assistance and hopefully influence in a positive way the outcome of those discussions. So thank you both. We are going to broaden the conversation at this point, and I'd like to welcome Jason Slotnick. Jason is our Senior Policy Advisor at RAAP. He has also worked in the policy arena throughout his entire career, both at Bio as well as a policy advisor to NORD. And he is one of a very, very small group of experts on CMS and payment policy. So Jason brings a very, very unique set of tools and thoughts to some of the issues that we are going to see occurring in the PDAB space moving into 2026. and that is namely the expansion of the toolkits that PDABs want to be able to use to incorporate both MFP, which is a tool that was provided to CMS in the Inflation Reduction Act, and MFN, which is a market basket concept that hasn't been implemented but has caused a lot of discussion at the state level as a potential surrogate for a UPL. So Jason, I'd like to welcome you.
Thank you very much. Sorry, I'm a few minutes late. I had to get on another call. Nice to meet everybody. Thank you, everybody, for your time on this Friday afternoon.
So Jason, I'd like to turn some time over to you to actually share with us what is MFN and what is MFP, and why are they even of interest to state PDABs and stakeholders at the state level?
Okay. So, as I'm sure has been discussed and is very familiar to everybody on this call, the PDAB is a significant process, and the PDAB requires a lot of work and effort and back and forth, everything Mike's talked about, to come up with a price of a drug that the PDAB feels is an appropriate price for the four corners of its respective state. So put that on the left side of your scale, and now let's go over to the right side of the scale, where we have an MFP or an MFN. And you will, after I briefly describe what each of those metrics are, see why the state would much rather use what they see on the other side of the scale as compared to the PDAB, because it's just flat out easier and actually may result in a lower price. So as Mike said, MFP, maximum fair price. Maximum fair price emanated from the Inflation Reduction Act as the acronym and the price that is set between as a result of the negotiation between CMS and the manufacturer for the selected drug of that year. In about 4, 8, 9 weeks, as you may know, probably, we will have our first MFPs going into effect January 1 in the Medicare program for 10 drugs. In the next 30 days, CMS is going to announce the price for the second selected drugs that'll go into effect in 2027. And those maximum fair prices will be very public and is the price by law that the patient must pay and can only pay at the point of sale. So you're sitting in Colorado, you got all this scar tissue and brain damage for PDAB, and you've got CMS that did all the work for you. Which one are you going to choose? That exists, that is there. As Mike said, we haven't seen anything yet on MFN, which stands for Most Favored Nation. Most Favored Nation is a concept that goes like this. Why should Americans or my citizen resident of my state pay more for the same drug than those across the pond are paying? Why should somebody in Colorado pay X dollars for Ambril while those in England, Germany, France, Canada are paying a lot less? We're not going to import the drug, we'll import the price. And we can import the price in one of many ways. We can take that, as Mike said, the basket of countries. How do we identify that basket? It could be OECD countries who have a certain percentage of our GDP, call it 60%, which was discussed in a executive order that the president laid out. Or we can draw the line a little higher and make it the G7 countries, us, one, United Kingdom, Canada, Japan, France, Italy, right? Those are your 7. And then maybe you add in a Denmark or a Netherlands, whatever, and maybe it's an index, or maybe it's the second lowest, whatever it may be. But if you're the state and somebody else is going to do all the work for you to come up with a price, maybe it'd be a little bit more than the PDAB, but you're absolved of the political process, the cost of standing up the PDAB, the cost of implementing in the PDAB. Why do it? And that toothpaste is sitting there out of the tube. Why squeeze your own? And so these concepts are, what is there? MFP, MFN is being discussed. And as you probably have seen, the president has talked a lot about it. And already we have 3 companies that have gone in and negotiated other deals that have committed to, amongst other things, a global launch price to avoid tariffs. We are going to see more companies doing the same. And so now here we sit as an inflection point, which is, will that be enough for the government? Will the administration say, you know what? I got 8 pharma deals or 9 pharma deals or 17 pharma deals because that's how many letters were sent out. I don't need to do anything else. I got these companies to commit global pricing. It covers 90% of the drugs, right? Because yes, we live in RAAP. We live in a world where, right? But by definition, these are rare, right? But so it's not a big piece. So is this enough? If it is, great. If not, well, the government has other tools. And the government has already tried to use those tools during Trump's first administration. During Trump's first administration, the administration put out a proposed rule to import, under the same policy, most favored nation, create a list of top 50 Part B's and boy drugs, looked across the pond, bucket of countries, chose the lowest price, and now it replaced the ASP here. So one model that's sitting at OMB or it's being discussed looks a lot like that. It's called the GLOBE, GLOBE. Has some fancy acronym, I forgot what it stands for. Secondly, right, it's not only B as in boy products, we have a D as in David channel, pharmacy channel. Rumor has it that the second model at the OMB, called the GUARD, may be trying to come up with some creative demonstration program that similarly takes the price of a pharmacy drug and brings it here for the pharmacy channel of D as in David. So time will tell as to how far this MFN goes or not. I think the point that keeps RAAP up at night is, even if you don't see the globe, even if you don't see the guard, the toothpaste is out of the tube. The federal administration has many more politics to manage than any one individual state. And it's not out of the realm of possibility for a state legislator in this upcoming session to Google, hey, what is the price of XYZ drug in Germany? Bring it to a committee meeting and say, why suffer the scar tissue and brain damage of a PDAB, both in politics, policy, and flat out expense, when we've got this lower price just sitting there? And
So-
with that, Mike, it's probably happy hour time and start drinking heavily for most of our people here. It's a separate conversation.
So, Jason, as you look at those tools, we've seen Colorado, as you had just pointed out, that took an MFP for Enbrel and said, okay, this is going to be statewide now. And as we look at that from our rare lens, and then I'll open it up to Rainier and Bill to comment on their perspectives. What are the challenges of taking that negotiated Medicare price, that MFP, and then applying it into the commercial space in a state, and say, okay, our state's going to do that. What are some of the challenges for rare patients and for the ecosystem in general?
Well, Mike, yes, right. I mean, of course, like I just said, right? So the state, so let's roll my hypo out a little bit more. The state can then take that MFN or even MFP and make it the reimbursement rate, right? But we have to also recognize what the state has jurisdiction over, and right, it's the fully insured plans and maybe Medicaid. I'm going to guess that the Medicaid price, probably with rebates, right? Maybe they're not financially incentivized to replace it on the Medicaid program, given rebates matching AMCAP or whatever. They would have to be careful on doing that. And similarly, on the Medicaid side with MFN, they'd have to run their own numbers. When it comes to fully insured, then they could sort of do that. And so therefore the advocacy for an organization like ours, right, should be to educate that you're doing more harm than good when you use it for a rare disease product, a drug, a biological that treats a rare disease. What you are really doing is hurting the patients because that MFN or that lower price that is in the system is not helping them much because their insurance program is really subsidizing it. That actual price is too high, you know. So I think we should consider trying to continue to educate at the state level why any kind of policy like that is going to be bad, not only for patient access today, but as we've discussed for future products and patients, because there just won't be, two things, right? Let me finish on the current. They run the risk of the state patients not being able to get it, and because of distribution, or number two, in the future, if you're not investing by reimbursing by not reimbursing, you are likely also not investing in the next generation of cures. And so we need to also continue to remind legislators that not to be penny wise, pound foolish for the future of their residents.
Rainier, I saw your head nodding at a couple of things as we were going. Would you like to weigh in here as well on the use of these two tools?
Yes. I am not as familiar with the details and ins and outs of MFN quite yet. I'm actually digging into that myself. But as far as MFP, a lot of what you were talking about, Jason, I have lots of concerns because one, with MFP, if states are just going to use MFP on a particular drug, my problem with that, number one, is each state has specific affordability issues. And
Right.
that drug that, there's MFP on, that might not be a problem for that state. And that state has other drugs they need to be looking at. And then they are also not thinking about the fact that using MFP could affect their state budgetary issues as far as Medicaid rebates and 340B rebate issues and things of that nature. Then also with using the MFP pricing, my understanding is that with the government, as far as reimbursement, their manufacturers are still going to make, like, for example, pharmacies whole. If you are talking about a state situation, the state doesn't have or they're going to have to come up with, appropriate funds to make reimbursement whole for people who have problems because of using an MFP. So that's a whole different set of issues that they haven't even thought about or considered.
Agreed. And that's a really good point, Rainier, about the MFP and the manufacturer. The MFP law requires the manufacturer to make the pharmacy whole. Because like you said, right, the pharmacy buys it at a certain price, the patient's paying the MFP, there's a delta there that is subsequently put back in by the manufacturer, right? And CMS stood up that whole process. So yeah, I mean that exists too. And if that doesn't go with, then we've got a bigger problem, to your point. But I don't want to always be a Debbie Downer here, and suggest that a classic DC term that Mike knows very well, which is never miss a crisis as an opportunity. And I think that we still have all the horses in the barn, and our opportunity is to lock the doors. And what I mean by that is we have an opportunity now to go in and certainly re-educate seasoned legislators, if not initially educate newer legislators who don't appreciate the business model of developing orphan drugs, who don't appreciate the details of that specifically, and use it as an opportunity to educate and possibly develop champions who can continue to advocate for appropriate market access policies to continue to make sure that those most vulnerable patients in their state continue to have access.
And we did get a comment from one of our participants, and I was actually going to think about how to close by saying this. And so I want to thank Dean for actually making this point, particularly when we look at rare diseases and rare therapies, both, how they come to the market, how they're made available on the market, and the patient populations that they serve, is that rare diseases are often different in dealing through some of the nuances of these kind of bigger picture issues, whether it's MFP or MFN or even a UPL. You have, out of state issues, so for example, rare disease patients often go out of state for their care or for their therapies. Specialty pharmacies or drop ship just in time pharmacies that serve rare patients are often out of state. And so they're outside the scope of the UPL. And as Jason said, how do you make sure that everybody's made whole in the system based on a UPL? So there are some nuances that rare disease patients and the ecosystem that supports them are going to face with the application of these tools. And so it's just a point that Dean wanted us to bring out as we were preparing to kind of close up the discussion. Jason, I think you had something you wanted to share or add?
No, well said. It's all good. I think I just want to really underscore what I said before. I think we can make this crisis into an opportunity. Those of you that attend NCSL, there's that could be a good place. There's always new legislatures entering and looking, right? And I think this is a nice opening. Hey, you may have heard about MFP, right? To Rainier's point, you may have heard some of it. Let me tell you why it's bad for orphan. Right? Let's do that. I think we should pivot to that, and we make a lot more. We'll capture a lot more bees with that honey than we will with the vinegar.
I absolutely agree. Bill, anything else that you wanted to add before we conclude the webinar? You're on mute, Bill.
No, thanks. No, I think this seminar just reminds me I have a lot more to learn and to catch up on. I'm always very concerned about the disincentive for the development of new drugs. How is that going to impact the development of new drugs? And, another thing, the Boston Globe today just had a big article on pharmacy deserts. And how are these policies, sort of outside the patient group, going to impact pharmacies? Are we going to see more of them hurt and closed? Because these growing number of pharmacy deserts is a real concern.
And I think, and Rainier can attest to this, as we've, been at the states and lobbying, Bill, often we will go hand in hand with the pharmacies into some of these meetings to talk about PDAB. And often I hear the stories about from a pharmacist about how when they dispense a therapy, it's often months of adjudication, back and forth with the plans on the cost, et cetera, before they even finally get paid. So that when they dispense, they don't know ultimately what they're going to get paid at the other end. And PDAB, through implementation of a UPL, creates a level of uncertainty and risk to their ability to dispense. And so, as they look at it, just like the plans do, they're going to have to be able to have that certainty around both being able to dispense, being reimbursed, and being able to make it available to a patient. And again, that's part of the fabric that's being pulled on by a PDAB. Rainier, did you want to add to that?
Oh, just to definitely reiterate what you just said, and also just lost my train of thought that quickly. Sorry. I was so thinking what you, I just lost my train of thought. Yes, I do want to support what you said about the pharmacists and the fact, I just remembered, yes, there have already been some pharmacists who discussed the fact that they're possibly not going to carry some of these drugs that have MFPs because of that reimbursement issue. And also with even something like a UPL, between the UPL and like PBM contract and things of that nature, if the UPL is too low and the pharmacist is already getting, poor reimbursement, that can make it worse. So all of things together can make things, really hard on pharmacies who are already closing.
Right, but we should think about how many of our drugs are actually accessed and dispensed at that point of sale at brick and mortar versus mail order, to just sort of figure out at what length and breadth and depth we're going to extend our advocacy and educational efforts around that. Pharmacy deserts are an important, like Bill said, right, issue, right, because that hampers access. Well, we should double click on sort of saying, is there been a decrease in the choices that patients who are suffering from a rare condition or living with a rare condition are having in their pharmacy choices, right? That is something that we could double click on and sort of see, oh, there is a narrowing of that. Thereby, as Mike knows, and somebody who stood up pharmacy distribution networks and then making it worse for the patient. I mean, that's a secondary issue that we could certainly think through in our advocacy, but that's a big and by the way, there's room for the states to regulate that on federal side too, right? Given recent court decisions. So, Bill and Rainier, that could be something else that RAAP looks into as we add on to the initial advocacy of preserving access, right, and not doing any of these harmful pricing decisions on a rare disease drug.
And I think, that RAAP would be excited to work with both of you on that, and would love to follow up with you after this webinar. Well, we are reaching the top of the hour, and I would like to thank our panelists for participating in this discussion. We had a very direct discussion about New Hampshire, as well as then around the MFN and MFP issues, which we are starting to see at the state level. And so I want to thank them for helping bring some clarity to those issues, to look at the complexities. Obviously, there are areas where we don't have a lot of clarity, particularly on MFN. And so it is an area of interest for rare disease patients and families as we start to look at how we can continue to improve on accessibility. And so thank you again to our panel. Thank you to our attendees this morning. We appreciate the questions. If there are any follow-up questions, please feel free to forward those to us. And we look forward to hosting you all again in about a month at our next PDAB webinar. So again, thank you to everyone, and this will conclude this session.
Thank you.
Thank you, everybody. Have a good weekend.
Yep. You too.